afternoon. I'd like to welcome you to today's Medical Center Hour. I'm Marcia Day Childress from the Center for Biomedical Ethics and Humanities, and we're pleased to bring you these weekly programs. Our program today at lunchtime has the ominous title, The Deadly Dinner Party, Doctor as Detective. Outbreaks of disease are a part of life on our planet, whether it's a single unusual case or an outbreak affecting hundreds of patients across a wide swath of geography. Think, for instance, of the 1,600 plus cases of salmonella we read about all across the United States earlier this year that happened as a result of tainted eggs from contaminated Midwestern farm facilities. Anyway, with all of these cases, it often takes considerable medical detective work to ferret out the cause and to prevent the next case. Epidemics and other episodes of puzzling illness have long captured the imagination of historians, medical personnel, writers, and the public alike. The modern medical detective story has an illustrious history too, including the more recent work of Burton Ruochet, whose tales enthralled New Yorker readers for decades. In the tradition of Ruochet, physician-writer Jonathan Edlow talks in this Medical Center Hour about the doctor as detective, and he uses illustrations from his own books of true medical detective stories. His two books are called Bullseye and The Deadly Dinner Party. The UVA bookstore is here with copies of both books outside the auditorium, and you may visit them, and Dr. Edlow will kindly sign books following the program. Our program last week focused on investigations of a different sort, a criminal sort, the Burke and Hare murders, pursued in 19th century Edinburgh, which was at the time the hub of state-of-the-art medicine. We address a different sort of investigation today, doctor as detective. Jonathan Edlow comes to us from what many view as the center of the medical universe for our time, Boston, where he is vice chair and professor of emergency medicine at the Beth Israel Deaconess Hospital and an associate professor of emergency medicine at Harvard Medical School. You'll find a short bio of Dr. Edlow in your handout. I'd like to thank the Department of Emergency Medicine here at UVA for co-sponsoring Dr. Edlow's visit with us today. And again, I would encourage you to visit the bookstore's stand outside at the end of the program. Dr. Edlow will speak, and then we'll have some time for conversation with him with your comments and questions. Welcome, Jonathan Edlow.
Thank you very much. So thank you. The university has been very hospitable, and it's really nice being down here partaking of Southern hospitality. I got interested in this many years ago when I had some family members who were involved with the outbreak of Lyme disease, and we're going to talk a little bit about that. And it really is sort of the medical detective story par excellence. When I was young, I used to like the Sherlock Holmes books. I read the whole thing, and then I read the whole thing again when I was in college, because they're just very cool stories. And it's interesting that you mentioned Edinburgh, because the doctor, James Bell, on whom Arthur Conan Doyle sort of based Sherlock Holmes a bit, was a practitioner in that neck of the woods. So we're going to talk a little bit about some epidemics, about some cool stories. I'm going to talk a little bit about each of the books and some other epidemics. I'm only going to talk for about 30-35 minutes so that we can talk and chat afterwards, and I'll be happy to answer any questions that I can. So this top one here, that's Auguste Dupin. This is Edgar Allan Poe's detective, and this is the case of the Purloined Letter, where sort of the clue is left out in plain sight, and he's one of the famous detectives, and of course this is Sherlock Holmes. And you know, as a doctor, a lot of cases that you see are really very pedestrian. You know, somebody twists their ankle on the soccer field, they have a tender swollen ankle, and it's a sprained ankle. And some patients come in and they have a sore throat, and they have some pus on their tonsils and a fever and some swollen glands, and they have a strep throat. And there's not a whole lot of detective work that takes place in cases like that. And then there are other cases where you just have no clue what the patient has, and you really have to spend some time. And you know, medicine is, I'm 57 right now, and medicine is shifting a lot from taking careful detailed histories and doing a careful physical exam to let's get a CT scan, let's get an MRI. And there's a lot of mysteries and a lot of answers that sort of don't yield themselves to these fancy tests. They're incredibly good diagnostic tests, and many times they do give us answers, but sometimes it's the history. And those are the types of stories that I have focused on. So a lot of times there's a what? There's the sore ankle that comes in, there's the sore throat that comes in, and what we need to do is figure out the when, the who, the where, and that's how we figure out the how and the why. And in a complicated illness, this is kind of important. In the setting of a book, it's called Plot and Character and Settings, and in the setting of medicine, it's called Preventing the Next Case, when you figure out that how and the why. And we'll talk about how this actually plays out. Epidemics are nothing new. Epidemics have been going on a long time even before this, but this was the 5th century BC, where there was a huge epidemic that wiped out about 1/3 of the population of Athens. Athens, of course, at that time was fighting Sparta. Pericles was the head of the Athenian Senate, and he died in this. And many people think that this outbreak, whatever it was, and medical historians are still debating what the cause of this outbreak was, probably had an effect on the war. People think that it might have been influenza, it might have been typhus, it might have been typhoid, it might have been malaria. People really don't know. We're going to shift forward a bunch of centuries, a millennium and a half or so, and talk about the London cholera outbreak of 1854. And John Snow was an anesthesiologist who practiced in London at that point. The prevailing theory or theories about what spread cholera were unknown. The bug was yet to be discovered. It would be another 30 years before Robert Koch would discover the bug in a Cairo outbreak of cholera. People thought it was the air, people thought it was all sorts of, evil spirits and that sort of thing. And the germ theory hadn't been discovered yet. But Snow, from prior observations, and contrary to the prevailing wisdom, thought that this was a waterborne illness. And this outbreak erupted, and he had a chance to test his theories. So the what was all these cases of cholera started coming on. The when is that you could trace it to like the evening of August 31st in 1854, when dozens and dozens of cases of cholera began erupting. The where was the Golden Square area, and there were literally over 2,500 people that died in London, not just cases, but deaths from cholera in that area. And the who, this gets into the ghost map that John Snow developed, which I'm going to show you in the next slide. He basically went around house to house and with a pencil and a paper began checking off how many people had died of cholera in these different places. And you can see that when he cycled this was the Broad Street pump location. This was where people came to get their water, and that's how they got all of their water for cooking, for drinking, for everything else. And each of the dots on the map represents not just a case of cholera, but a death from cholera. So he looked at this map and he said, it's all really tightly clustered around here. But he also found an interesting thing. And he found that there was a brewery 1 block from the epicenter. There were 70 employees at the brewery, and none of the 70 employees got cholera. And it just seemed very odd to him. And you can see here, nobody around the brewery got cholera. And yet, a block away, almost everybody in the household was dying. So why didn't the workers get cholera? Okay, you win the prize for that one. Yeah, I mean, if you had beer to drink at lunch, why drink water? So they would drink beer, and he put this together, and he basically asked the government, the local government in that neighborhood, to take off the handle of the Broad Street pump, and the cases rapidly declined, and it went away within a few days. So this is kind of one of the, again, one of the story par excellence of medical epidemiology, where someone does the work, figures out the who, why, what, where, and the how, does an action to prevent new cases. It's also the concept, because I love the Sherlock Holmes connection of the dog that didn't bark. Why did those 70 workers in the brewery not get cholera? And in Silver Blaze, the conversation goes like this: Inspector Gregory, is there any other point to which you would draw my attention? He's asking Holmes. Holmes responds to the curious incident of the dog in the nighttime. The dog did nothing in the nighttime. That was the curious incident. So sometimes what doesn't happen is as important as what does happen. And as a clinician, when I'm talking to a patient, there can be clues in what doesn't happen that are just as important and just as pregnant as the clues about what did happen. If you're expecting something to go along a given trajectory and all of a sudden it's off that trajectory, there's a reason for that. And it just gets into the little bits of clues that help a detective, that help a physician figure out the answer to something. And I'll also say that in addition to the dog that didn't bark, there were also people that got cholera that shouldn't have. There were people that lived in other distant neighborhoods. And when Snow began to investigate those, he would find in one instance that because this household liked the taste of the water from the Broad Street pump, they would send their servants with a wagon and some jugs, collect water, bring it across town. So they died, but when they looked at where they got the water, it was from the Broad Street pump. So sometimes it's the dog that didn't bark, and sometimes it's another animal that does bark. There have been lots and lots and lots of epidemics. There will always be epidemics, almost for sure. And certainly since I started practicing, all of these and more. And one of the ones that sort of captured my attention because of my familial ties to some people that lived in West Lyme was the outbreak of Lyme disease. And I got so interested that I wrote a book about the history of Lyme disease. And it's kind of cool when you look at it. In 1975, this is Polly Murray, and she lived in Lyme, Connecticut. There was another woman named Judy Mensch that lived in Old Lyme, Connecticut, and they didn't know one another. There were odd goings-on, and what Polly Murray noticed was that people in her family were getting sick, neighbors were getting sick. Within a one-block area of Judy Mensch, one country block that is, there were 6 people with arthritis. She had lived in Manhattan and grown up in Manhattan, and her daughter and 3 other kids in that square country block had been diagnosed with juvenile rheumatoid arthritis. She had never heard of juvenile rheumatoid arthritis. She didn't know anybody with juvenile rheumatoid arthritis. And yet in this little country area, there were a bunch of people within a very narrow geographical area. So again, the who's, the what's, the where's, these are all things that keep coming up. Polly Murray did the same thing, and basically people kept saying it's juvenile rheumatoid arthritis, or you're crazy, or it's a strep throat, or it's whatever. She saw about 30 doctors over it was an 8-year period of time, and each one had a diagnosis for her. And it's easy to jump to conclusions. It always reminds me of the story about the woman that goes to visit her son for dinner, and the son is living with this woman, and the circumstances under which they're living is a little bit ambiguous. So halfway through dinner, the girl is off doing something in the kitchen. The mother says, "What's the story with you and this girl?" And the guy says, "Mom, look, it's a big apartment. There's 2 bedrooms, hers and mine. It's purely platonic." The mother says, "Good, because frankly, I don't like her very much." A couple days go by. The girl says to the guy, "Sweetheart, I can't find our good silver candlesticks anywhere ever since your mother was here." And he said, "You're not insinuating that my mother stole the candlesticks, are you?" She said, "I didn't say that. All I know is that since she's been here, can't find them anywhere." They search all around. They can't find the candlesticks. And a day later, he kind of summons the courage, and he sends his mother an email. He can't even bear to speak with her. He says, "Dear Mom, I'm not saying you stole the candlesticks, and I'm not saying you didn't steal the candlesticks. All I'm saying is that since you've been here, we can't find them anywhere." He gets a prompt response back. "Dear son, I'm not saying you're sleeping with this young lady, and I'm not saying that you're not sleeping with her. All I'm saying is that if she were sleeping in her own bed, she'd know where the candlesticks were." So it's very easy to jump to conclusions. You put 2 facts together, they happen temporally, at the same time, and your mind begins to go in a certain direction. And in modern parlance, we call it diagnostic anchoring in the language of medical education, where you're locked on a diagnosis, and even though there are clues that it's the wrong diagnosis, you're just focused on it like a dog on a bone, and you can't get rid of it. So David Sneidman, who this is a picture of, at the time was working for the CDC. He was sort of on loan to the state of Connecticut as an epidemiologist. And he started, he was actually away in Europe when both Polly Murray and Judy Mensch, within a 1-week period, both called the Connecticut State Department of Public Health, saying all these kids are getting arthritis. And the guy that took the messages said, well, arthritis doesn't cluster, so, it can't be anything, jumping to a conclusion. But he wrote down the messages, and when David Steinman came back from Europe, he looked at him and said, you know, he was curious. He said, that's odd because arthritis doesn't cluster, but this phenomenon is clustering, so let's look into it. And he basically did the same thing that Snow did. He got out a paper and a pencil and a map in this case, and he basically started writing down where the cases were. And the cases were always not in the city center, but in the rural areas. There were cases sometimes in the same family, but it was never the same year. It didn't seem to be person-to-person transmission. But he was using the same tools that any medical epidemiologist would use. And this is a map of the area in Connecticut, and you can see that the Long Island Sound pretty much runs east-west and is horizontal, and the Connecticut River punctuates it. And there's a west bank and there's an east bank, and the three towns on the east bank are East Haddam and Lyme and Old Lyme. And what they did is they started counting cases, and they started doing some tick surveys, because very early on a couple of the housewives had said to the investigators, you know, it seems like the last few years there have been a lot more ticks. And what they found was that the frequency of both the ticks and the disease, despite the fact that the Connecticut River is, I don't know, a couple hundred yards wide at that point, but there was over a 10-fold higher incidence of both Lyme arthritis as well as ticks on the east bank compared to the west bank. So, you know, they looked at what do the patients have in common, a standard epidemiologic sort of thing, and they found that a lot of these people were children or very young adults. As I mentioned, there was an absence of person-to-person transmission, and it seemed to be clustered in time during the warmer months of the year, and it seemed to be clustered in space in rural areas. And these were some of the things that they were seeing. They were seeing arthritis, and you can see that that knee is very, very swollen. Patients with Lyme arthritis, and I understand there's a fair amount of tick-borne disease in Virginia, you know, the arthritis tends to be really a lot of swelling, but it's not hot and red and warm like an acute infectious arthritis. And they began noticing this curious rash that we now call erythema migrans. This is actually one of the emergency department nurses at Beth Israel. It's as much of her as I ever got to see. But you can see that it's a target lesion, and it's fairly typical. And when they started looking into the history of the rash, they found that this rash had been diagnosed as far back as the 1880s. The first diagnosis of erythema migrans, or the first description, I should say, was in 1910 in Sweden, and the first rash attributed to Lyme disease, which has a big long name, acrodermatitis chronica atropicans, had been described by a German family practitioner in 1888. So this rash went back a long ways in Europe, and there was sort of different theories about how to treat it. And this is, you know, different people. There were rheumatologists and there were dermatologists. Bill Burroughs, who I think he's still at the Scripps Institute in La Jolla, was a young dermatologist stationed at the submarine base in Groton, Connecticut at the time. And he was working with an internist there, Bill Nast, who was an internist who went into gastroenterology and died about 8 years ago. And the two of them on the subbase in Groton, Connecticut had 4 patients over the summer of '75. And this was the summer before Polly Murray and Judy Mensch had made their calls to the State Department of Public Health. And they had these rashes, and they were feverish, and they had a little bit of joint pains, and it was a weird rash that Burroughs had never seen before. And he was in the habit of driving down to Yale for dermatology grand rounds every Wednesday, and he brought photographs of these rashes, and he showed them to people. And there was a Danish physician in the audience who said, well, that looks a lot like erythema migrans that we've known about in Europe for decades. And after the first case or so, Burroughs began to treat these patients with antibiotics because, you know, he was seeing the front end of the disease. And he was seeing patients that had a big red rash, low-grade fevers, and it seemed intuitive to him that it should be an antibiotic type thing, an infection. Alan Steer, who was a fellow at Yale in rheumatology at the time, he was a rheumatologist, and he was focused on the joint findings. And the joint findings are much later, and it's not as clear that it was an acute infection. It was not as clear to him and his colleagues that this was something that required antibiotics. So there was a big thing about early versus late, virus versus bacteria, antibiotics, yes or no. And this always reminds me of the story about asking the right questions. So this guy's driving to work, and he gets in a car accident, dies, goes to heaven. St. Peter says, your name's on the list, you can get in. You only have to answer one question. He says, what's the question? St. Peter says, well, you just have to spell one word. He says, what's the word? And St. Peter says, love. And the guy says, well, that's easy, L-O-V-E. The guy says, you're in, that's all there is to it. All of a sudden the phone rings and St. Peter says, yes, sir. Yes, sir. Right away, sir. And he hangs up and says to the guy, look, that was the boss. He needs me for a quick meeting. It'll take about 30 minutes or so. Do you mind manning the desk? Here's the list. It's the same question for everybody. We've learned that standardization is a good thing here. So the guy says, sure, no problem. 15 minutes later, his wife appears. He says, sweetheart, what happened? You were fine when I left for work. She said, I got a call from the hospital that you were really bad off. I drove like a maniac. I got into a car accident and I got killed. He said, my God, that's horrible. Just a minute. He says, your name's on the list. You can get in. You've just got to answer one question. She says, what's the question? He said, you've just got to spell one word. She says, what's the word? He said, Czechoslovakia. So, asking the right questions is an important thing. And the dermatologists and the rheumatologists were asking very different types of questions. And it's like the story of the blind men and the elephant, where this comes from India, it comes from Africa, it comes from China. It's not clear where the origin of this story is. But different blind men are feeling different parts of the elephant. And, you know, the one that feels the tail says the elephant is like a rope, and the one that feels the leg says the elephant is like a tree, the one that feels the tusk says it's like a spear, and so on. And they're all partially right, but they're all partially wrong. And again, it's the concept of seeing things from different perspectives, from top, bottom, front, side, and trying to get a sense of what the whole is. Willy Bergdorfer finally found the bug, and it was named after him. And within about a 7-year period of time, the whole mystery of Lyme disease got sorted out. Although there's still a lot of controversy about chronic Lyme disease that I talk a little bit about in the book, but will not talk about here. So I got interested in these medical detective stories, and I started writing them for Ladies' Home Journal. And these are cases, these are all true stories. They're things that could happen to anybody. They're things that, some of them are systems or diseases where the patients almost died. And it really took some detective work to sort them out, to make a diagnosis, to figure out how a cluster of cases pulled together. And this is one I call the forbidden fruit. And it's a story about an outbreak of dysentery that occurred in a small town in Massachusetts, mostly kids. Some of them began to develop renal failure, kidney failure, and some of them need dialysis. And this is a story about how these strange cases were related and what happened and how these 6 kids got so sick. I'm not going to tell you the answer, you've got to buy the book for that. Can you imagine a cuter kid? It's not my kid, it's like the cutest kid that you could find. This is a story called The Baby in the Bathwater. This is a Missouri toddler, and this kid also, Steve, is from Cape Girardeau. She got sick, she got an acute gastroenteritis, which is a very dime a dozen sort of thing for a pediatrician. And the pediatrician talked to the mom, they put her on a diet, and the kid kept getting sick. So they got a stool culture. And the culture came back with this organism that's only found in the tropics. Little Katie was her name, had never traveled more than 10 miles from Cape Girardeau, Missouri. Nobody else in the town was sick. Nobody else in her daycare was sick. And this is a story about how actually the mother in this case and the babysitter figured out where that tropical bacteria came from. This is the case of the overly hot honeymoon. And this was a young woman. She was a college student at Bowdoin College in Maine. And she needed some blood testing in order to go for this semester in Rome. And she got the testing, and she had too many lymphocytes. And in the process of working that up, they kind of found some other abnormalities, but they sent her off to Rome. She had a good time. She came back. And then she noticed that she was losing weight. She was eating like fork for fork with her now husband, then fiance, who was a football player, and yet, she was losing weight. And she got like so emotional before the wedding, they almost called off the wedding. And this is a story about how, again, the family, a lot of these stories, the family is heavily involved in sorting things out. And it brings up the general principle that, as a patient, it's better to be an active patient than a quote-unquote good patient. Good patients sort of, most of the time it's not a problem because most of the time doctors make the right diagnosis and do the right thing. But it's good to question things. It's good to be skeptical in general on the planet. But as a patient, it's good to ask questions and it's good to be skeptical. Monday morning fever is this guy that they thought had a heart attack because he was having these chest cramps and muscle pains. And it was odd because some of his co-workers were having very similar symptoms. And the weird thing was that some of them did and some of them didn't, even though they were all doing the same process at work. And the other odd thing was that they tended to get better on the weekends and worse, during the week. And, the bosses began to wonder, is this, mass hysteria or people trying to get out of work? And this is a story, again, about some real medical detectives that really figured out exactly what happened and why some of these people were getting sick. An airtight case is another one. This was a guy, he's a bank executive. He lives outside of Boston. He works in Boston. And he works in a building, very much like this, where, you can't open the windows. You're at the mercy of the HVAC system for that particular building. He gets sick. He has a cough. He has fever. They diagnose pneumonia. They treat it. He gets better. And he has several bouts of this before they finally figured it out. He had these nodules that they were about to take him to the operating room to do a biopsy because they thought he had cancer. And here, this is another case of a family where they just didn't believe the diagnosis, and they, demanded a second opinion. And he got a second opinion, and the doctor in this particular case went to extraordinary lengths to literally do some field detective work to figure out what the diagnosis was. A study in Scarlet, which of course is one of the names of the first Sherlock Holmes novelette. Group of doctors at a conference in New England. They set them in nice places, so they set this one in the fall. And they sit down, a group of 7 people, to eat lunch. And one by one, several of them just turn bright red, feel itchy. And the first one thought it was an allergic reaction, but then when the second one developed the same symptoms, it would be odd for 2 people who are unrelated to get the same allergic reaction. Was it mass hysteria, or was it something more sinister? The case of the unhealthy health food is this woman that was incredibly healthy. She was a scuba diver, she jogged, she didn't drink alcohol except rarely, she didn't drink much caffeine, she didn't smoke, kind of almost a health nut. And she used to take a lot of different supplements and health foods. And then she began getting sick and she had to stop running, and she developed fluid that built up in her belly, what doctors call ascites. She too was thought to have a malignancy, and went through a myriad of diagnostic tests. This was before we had CAT scans and MRIs, but went through a lot of testing. And ultimately, there was a medical student on the case that had a fair amount of time on his hands, and he really did some bird-dog detective work and solved this case. And then the deadly dinner party. So which dish do you think nearly killed 3 of the people that had dinner at this dinner party? How many votes for the pasta casserole with sausage? We got a few votes for that. The meatballs? A couple won for that. The garlic bread? Nobody. The cheese ball? A couple for the cheese ball. Tossed salad? Okay, most people go for the salad. The fudge cake? How could fudge cake be bad? And then the wine. So I will give you the answer to this one, and I will give you the answer to this one, is the one that nobody guessed. It was the garlic bread. But exactly how it happened is a very cool story. So again, medicine can be a lot of fun. Every day I go to work, and I've been doing it for almost 30 years now. The reality, and Steve Huff and I were talking about this, there's all kinds of things that are hassles and get in the way, and administrative and bureaucratic stuff that occurs that makes our job less fun. But when you boil it down to its essence, it's still, you sitting in front of a patient trying to figure out puzzles. And sometimes the puzzles are, again, very easy and pedestrian. Sometimes the puzzles seem nearly insolvable. Sometimes the patient's really sick, you don't have time to think about puzzles, you just need to take care of them. But ultimately, it's still, been a fun and a privilege to work as a doctor for almost 3 decades. And every once in a while, you get a cool little puzzle that really is like a medical detective story. So thank you very much for your attention.
Thank you. We have plenty of time for discussion, for your questions. Maybe you can even work on him to divulge a few of the answers to the cases he mentioned. I will mention, as came up last week, that I don't know if you know, you're at one of the homes of Edgar Allan Poe. We have his college room preserved over on along, so you may want to take a peek at that. Anyone with questions? Okay, let me give you, let me pass you the mic so it goes on the tape.
I just said I'm curious about the garlic.
Well,
okay.
I need you on it.
Okay.
Garlic bread.
So this was a case where 3 of the people, including the host of the dinner party, got sick with botulism. And botulism is a disease that we almost never see. I've never seen a case personally. Botulism is a toxin which basically paralyzes muscle from working, and that's why a lot of people use it to paralyze the muscles that give them wrinkles. It's the same toxin. This guy had gotten some garlic, and the botulinum toxin is an anaerobic, it's an anaerobic organism. It has to be away from oxygen. So this company, the Colavita company, that's still present nowadays and makes sauces and oils and things like that, they had chopped up garlic that was preserved in oil. And because it was in oil, it was an anaerobic environment. And the organism, Clostridium botulinum, is ubiquitous. It's everywhere in the earth. So most of the time, you know, it's okay because things are washed off, or you cook your food and the toxin will die above a certain heat. But he made some garlic bread. He took pita bread and cut it up into slices like a pizza and spread this stuff on and sort of passed it lightly under the toaster oven. Not long enough for it to reach the heat that it needed to reach to inactivate the toxin. And the 3 kids that were there, fortunately, were watching some videos in the other room and never got the garlic bread because he took it out later. And one of the adults didn't have it, the other 3 did. The head of the host of the party was in the intensive care unit for, I think it was 3 or 4 weeks, was intubated on a ventilator and was very close to dying. The other 2 people underwent antitoxin treatment. There was a big product recall. There were some lawsuits involved, but that's essentially how the garlic bread did its thing.
Other question? Other question? Yes. Yes, back there.
We have a country home in Columbia County, New York, said to be the epicenter of Lyme disease in the world. I'd be interested to know whether you can confirm that or not. What I would like to ask, though, is one takes antibiotics when one thinks one has been bitten by one of those ticks. Is there a chance that that tick and the virus or whatever it is will get resistant to one's taking of antibiotics?
Okay, so the first part of the question about the epicenter, I don't think that that particular county is. I mean, there's 2 ways of answering, 3 ways of responding to the question. The first is that most of the early cases were described in that lower Connecticut River Valley region. The second thing is that if you look at the incidence of the disease, Nantucket Island off the coast of Massachusetts has the highest incidence. It's like 1 in 100 people. Incidence of disease is usually described in cases per 100,000, and it's like 1,000 per 100,000 there. So it's like 1 in 100, very high. The third way, and it's kind of interesting because Lyme disease, more than any disease I can think of, has sprung all of these kind of conspiracy theories and things. I've heard very well-educated people claim that the military went to Europe and got the Lyme disease bacterium, Borrelia burgdorferi, and brought it to this bio lab in Plum Island, New York, in Long Island Sound, to develop a biological weapon. And if you think about it, I mean, Lyme disease would be the worst possible biological weapon on the planet. It's not person-to-person transmissible. It doesn't kill people. You know, you might give someone arthritis in a year, but it's not a way to wipe out a population. And the other interesting thing is that people have gone to museums and gotten tick specimens and mouse specimens and taken little bites of them and used a technique called PCR that we use diagnostically medically, but it's a way to look for DNA of a specific organism. And Borrelia burgdorferi DNA has been found in tick specimens and mouse specimens from these museums from as far back as the 1880s in Massachusetts and also on Long Island. So it's been around a long time. The second part of your question about resistance to antibiotics, resistance is a huge issue in bacterial diseases in general. For some reason, this is a different kind of bacteria, and it hasn't seemed to develop any resistance at this point. And I would think that it would have at this point if it were going to, because we're treating so many people for it. You know, but bacteria are pretty clever. They've evolved over the millennia and millions of years like we have, and you know, they're in the game to survive. So who knows what will happen.
Another question? Just a moment.
My name is Adine Kelly from the School of Medicine. Do medical detectives like yourself need to be born, or is there something in medical education that can be promoted or improved among trainees to help them solve puzzles like this?
That's a hard question. I think that, in a sense, what you're asking about is about curiosity, because that's what it's really all about. You know, I think that most children are intrinsically curious about their environment, so I would say that people are born curious and therefore born to be detectives, as it were, whether it's about why the sky is blue or why this ant is crawling here or why someone has abdominal pain. On the other hand, I think that, you know, to some extent in medical education and in residency training, there is a piece of it, and there are other physicians in the audience that I'd welcome their comments about this. You know, to some extent it gets beaten out of you because you need to be quick and you need to see the next patient, and there are time pressures. Whether you're in an emergency department or in an office, there's that next task to do. And that gets in the way of curiosity being expressed. So I think everybody has the potential for it. And I think even everybody has the potential on a given day. Even, I mean, sometimes when I'm super busy at 6 o'clock on a Friday evening shift, I'm not so curious myself because I've got 13 patients I need to see. So I think everybody can do it, is the one sentence answer.
I have kind of a related question. I know you did your residency, or you did medical school at the University of Maryland.
Yeah.
And I know that there have been...
I thought we were the home of Edgar Allan Poe, by the way.
Well, I know. That's why I said one of the homes. But I know that there are a couple of physicians, or a physician and historian at the University of Maryland, who have often done some sort of medical historical grand rounds around interesting sort of detective work leading, you know, diagnoses of illness in famous people. And
they have, I'm blocking on the name now, but there's a named lecture each year where they get someone to do a case. In fact, they did the Athenian plague about 5 or 6 years ago. And somebody gets up, usually it's an infectious disease person, but not always, and they sort of go through what the signs and the symptoms, or why Beethoven died, or stuff like that. And they'll go through the data that are existent and sort of make their differential diagnosis, their list of possibilities, and say, I think it's this. And then there's discussion like here. So yeah, they didn't do that when I was there. That was a number of years ago. But they do have those rounds now.
So I'm thinking maybe that stimulates some of the curiosity again.
I think it does. I mean, you can't help but to.
I'm Peggy Shriver, also from Lyme-ridden Columbia County. I would like you to discuss briefly the role of the patient as detective. I think how often one goes to a doctor and you're not satisfied with the answer, and perhaps you go to 1 or 2 other doctors if you have the money, and you may get conflicting answers to your problem. that puts a patient in a rather awkward position. And I'm wondering, what do you advise a patient to do when you sense that the answer's not there yet?
That's a good and hard question. Number one, the reality is that the doctor has no information but that which the patient supplies us with. So the doctor can't do anything without getting information from you. And the accuracy and the completeness with which you provide the information is important. So one practical thing, because you may be nervous when you go to the doctor's office, it may be busy, you might not have the time, write out as clearly and cogently as you can on paper exactly what's been going on and sort of what you want to get accomplished during that appointment. Now that's obviously going to work differently in a doctor's office than it will in an emergency department. But you should really write down things because, memories fail. And how many times have you gone out of an appointment and said, I meant to ask him this and I forgot to? It happened to me about a month ago when I saw my primary care doctor. So you forget things, so write things down. Number two is that, there's always a balance between writing down a bunch of details that are meaningless versus writing down stuff and trying to be complete. And the reality is that you don't always know what's relevant and what's not relevant until the case is solved, so to speak. So, as a doctor, when a patient comes to me with like an 18-page list, I get a little allergic to that. But when a patient comes with like a 6-point thing, these are the really important things, and that helps me. So there's a balance between too much information and accuracy. The other reality is that doctors may ask questions differently. So I may ask you a bunch of questions and get this bit of information, and another doctor may ask you slightly different questions or a different sequence or use different words, and you may answer differently or not, and he might get different information. So it's sort of a two-way street of communication. And your last thing is, how do you know if it's the right answer or not? I mean, to some extent, and even though, a patient without any medical training doesn't know the medical side of things, there's a degree to which you kind of feel satisfied at the end of a conversation with somebody. So, a lot of times when I'm seeing a patient, I'll explain something, and they'll kind of look at me, and you can see in their body language or their facial expressions that either they don't believe me, or I didn't explain it well enough, or something's not right. And I'll say to them, you look like you don't believe what I just said. What's going on? What's wrong? And they'll say, I didn't understand it, but you forgot about this doctor. And sometimes it'll be that I forgot something they told me, and sometimes it'll be I didn't explain it clearly enough, and sometimes it'll just be a weird patient. There's different, no, seriously, there's different explanations for things. So there's a degree to which in your gut you kind of feel like this doctor is looking you in the eye, paying attention, not distracted, explaining what he's thinking or she's thinking. Because that's really, what I'm thinking is the most important thing I can give to the patient many times. And if you don't feel like they're looking you in the eye and being straightforward and unambiguous and clear and not distracted, then you need either spend more time or go to another doctor. But it's common sense type stuff in general. The reality is that sometimes there's going to be a doctor that gives you an explanation that seems very, very correct, but might be wrong, and that's going to happen too.
Hi, I'm Aggie Reeves, and can you talk a little bit about Polly Murray and the other housewife? Didn't they just have an extremely hard time being told they were crazy and needed psychiatrists, and their marriages fell apart, and their neighbors hated them because they ruined the name of Lyme, Connecticut? And they had to move away.
Well, all those things are partly true. I mean, Polly Murray from Lyme and Judy Mensch from Old Lyme, who again didn't know each other, basically were sort of like dogs with bones, and they were very, very, very persistent. They kept going back to doctors, and a lot of the doctors did tell them that they were crazy. Some of the doctors did say, go see a shrink. And they did meet with some hostility. I'm not sure about the neighbors part, although there were issues about property prices and real estate values because this, quaint little region was being associated with this horrible mystery arthritis. But they were people that were very driven, and they were experiencing the same things that all of their neighbors were experiencing, but there was something in their DNA that made them keep pushing forward as opposed to others that didn't. I've spoken with both of them. I've met Polly on several occasions, and she's actually a very gentle, soft-spoken person when you meet her. But she was extremely persistent with this quest. Does that answer your question?
Yeah.
My name is Bernard Williams. I distinctly remember when I was in medical school here at the University of Virginia, I think it was the second year, when preventive medicine was introduced into the curriculum. And it was scheduled on Saturday morning at 8 o'clock. And we all moaned about that. And it was really a topic of conversation prior to the seminar starting. And after it got going, I noticed that everybody came to that and everybody loved it. And even at that early stage of our careers, we understood, I think, at some level that medicine and everything else you can do in life is about solving a mystery or solving problems. So I've always had a sweet spot in my heart for preventive medicine. It was always so much fun. I didn't go into it, but I certainly could have very comfortably.
Yeah. Well, I hope we don't get too good at preventive medicine or I'll have to lose my day job.
Other questions?
There's one in the back there.
Okay, right.
Sue McCoy, this is a frivolous question, but the knife on your dust jacket is turned the wrong way. Is that symbolic of something sinister?
It is, but I'm not sure I want to say what.
I'd like to ask you what your experience now, fairly long experience, almost as long as your doctoring experience, but your experience as a writer, how does that particularly inform your medical practice now?
I think the way writing helps me with my medical practice is that a lot of what I do, a lot of what any doctor does is communication. And by writing, it just helps me be better at being clear in communicating. And to try to describe a concept in words that you're writing down and editing and rewriting and editing again and going through 10 rounds of edits, it just helps you be more clear most of the time. And it's, obviously it's one of those things like a mathematical asymptote where you're always approaching but never reaching. So hopefully I'm getting better at that as I get older and as I write more.
And how do you find the cases that you choose to write about? I mean, some may come to you in your practice or through colleagues
So
who talk about their practice. And then what do you do to pursue?
Well, I find cases from case reports and journals, from a CDC publication called the MMWR, the Morbidity and Mortality Weekly Report, newspaper articles, TV news, colleagues. And then once I find something, I really become journalist, not doctor. I find the sources, I call them up, I try to convince them to speak with me, I interview them either in person or over the telephone. I begin to put the story together and try to, just like a detective or a good journalist, find out all the different perspectives and try to corroborate information, try to get written sources, bits of charts or x-rays or news stories and things like that. And then I start putting the story together, and the way I write the stories is to tell a little bit about, the plot setting characters, a little bit of story, and then some medical backdrop. And then go back to the story, and then some more medical backdrop, and then ultimately close with, closing the story. Obviously, one likes to find stories that are good stories, that have a happy ending, that have closure to them. And the reality is that a lot of the medical mysteries, we never find out the answer. Those don't make good stories to write about. So it's got to have, and having interesting characters and interesting setting, you know, is something that just helps the writing go a little bit smoother. I think about things like, you know, propelling the plot by dialogue and have people talking. So, I mean, it's a combination of lots of different pieces of me.
Do we have other comments? Yes.
Just another Lyme question for you. So if they found Lyme as far back as 150, 200 years ago, any idea the change that happened that we started to notice in the 70s until now? Why so many new cases? Why more virulent? Has the disease changed? Was it not recognized earlier?
So I think that it clearly existed earlier. There were cases back from the 40s in Montauk, Long Island, which is the eastern tip of Long Island, where they called it Montauk knee. It was someone that got arthritis. And remember, people don't die from Lyme disease, almost never. So the arthritis tends to come and go, and they were sort of describing Lyme arthritis back in the 40s. There was another thing, I can't remember if it was Montauk or on Cape Cod, but they were calling these things spider bites, and it was probably the erythema migrans that they were referring to, even though there are distinctions one can make between spider bites and erythema migrans. So it existed, but at a relatively low level, number one. Number two, there's a lot of environmental changes that have occurred. And we think about, you know, that there are fewer and fewer and fewer trees, like in a state like Connecticut or New York. But the reality is that a lot of these areas were pasture lands and were cleared meadows. And we have more trees now in Connecticut than there were, I think it's 40 or 50 years ago. And people, instead of living in cities, tend to live out in, you know, kind of fancy areas outside of towns. So there's more potential exposure. In addition to that, the deer herds is an important part of it because, you know, most of the deer's natural predators like wolves and foxes and things have been wiped out by man. And it used to be that the deer population was kept in check by all these other natural predators. As we've wiped out the natural predators, the deer population has surged, and the adult ticks spend the winter and mate on the deer. So the deer is an important part in the biological cycle for the tick, and therefore for the Borrelia. So the deer population also, you can, you know, plot that, and it's gone up. So more deers, therefore more ticks, people living in areas where they're, you know, more exposed to the ticks, more trees, so it's really like kind of a perfect storm. Similar thing happened in Europe, and there were some other factors. You know, after World War II, a lot of the forest land had been decimated, either by bombing or people chopping down the wood for firewood, for heat, and for cooking. And there was a big surge in Europe after World War II. So there's a lot of environmental things, and even in little focused communities, there's things that one can get into that help answer that question on a sort of microcosm level.
Do we have any other questions, comments? Okay, I think we'll close, but I'd like to thank Jonathan Edlow. And
thank you all very much for coming.
He will be up outside the auditorium to sign books.